Good morning, everybody. I am so thrilled to be here, first of all. So thank you to everybody. I'm humbled. I'm honored. It's an amazing, amazing group of colleagues. So thank you. So my job this morning is to set the stage for our colleagues in Vermont who are doing amazing work. The health policy environment is changing. It's evolving. It's complex. So I'm going to try and go over all the different pieces in a very short period of time. Probably every single piece deserves its own discussion, but we'll try and do a really high-level overview of where we are. So to start, what I'm going to go over is who drives policy. Is it the federal government? Is it the state government? Is it a combination of both? Private payers, new players like Google and Amazon, what's driving changes in health policy? And also that we're learning as we go, and I think as we'll hear from our Vermont colleagues about next gen, it's the next generation because it's premised on what came before and what we've learned. And what do we want to think about in terms of incentivizing outcomes using value-based payment. So I'll try and come back to value-based payment, but as you all know, care delivery, care payment redesign, it's all very intricately intertwined. And then I'm going to end with some possible trends to expect as we move forward. So first, we have a new administration. We have new Trump health officials. We have Alex Azar, who's the Secretary of Health and Human Services. He's the second person in that post in a short period of time. And we have Seema Verna. So they both come to their positions with their own experiences, their own goals, their own objectives. But I think it's important to note them as individuals who are going to set the tone for what happens in this country, and this also will impact what happens in our own individual states. I just went through and pulled out two quotes, one from each of them, to try and figure out where they were on value-based payment, because there's been discussions about whether or not the federal government was still moving down this path. But I do think that they both are still moving down this path. How that happens and what that means is very unique to each one of them. But as exemplified in these two quotes, they both talk about rewarding value. So I think that the path is clear. We're going down this path. How we get there is up to individual states, but it'll be within the contextual framework of what the federal government allows and doesn't allow. I also wanted to go over quickly recent changes that impact care delivery. So these are administrative changes. There was a lot of talk about getting rid of the Affordable Care Act. We didn't get rid of the Affordable Care Act. But there are other things that the federal government can do that really impact what each of us do. So there are just three examples here. There are more: elimination of the financial penalties for not having health insurance, new restrictions on Medicaid recipients. We knew when Seema Verna came to town that one of her historical actions was to impose work requirements, and so we've seen that continue, and we'll probably see that continue. She has also said again and again that she wants to relax regulations and legislation and let states be the real innovators of change, so I think we'll see some more of that. And then new rules for insurers. So this is just one example of short-term policies that may allow for individuals not to all be included and to limit benefits. So then you have a balance. You have a balance between a new product that might actually reduce access or make costs more expensive. We'll see how that all plays out. But these are administrative actions at the federal level that impact how we all experience care. So I want to move on to Medicare. Federally funded, federally administered, and again, any state that wants to do a large all-sector initiative such as Vermont needs to work with the federal government, needs to work with Medicare to make sure that we are in alignment and that Medicare as a payer is in line with what a state will do. So Medicare, in terms of value-based payment, they had lofty goals. They wanted 30% of all Medicare payments value-based by 16, 50% by 18. There were mandatory demonstrations, bundle payments, and value-based modifiers for physician payment. That's MAPS and MIPS and MACRA. Got that mixed up. MACRA and MIPS, which I'll get into, but those are value-based payment for physicians, which are incredibly important in terms of drivers of value-based payment. What happened? The mandatory demonstrations were ended. They're now voluntary. But we learned some things. We learned that practice size matters, bigger practices do better, and that at least initially in terms of MIPS and MACRA, physicians did not fare so well in terms of the incentives that were offered. So these are things to learn and to think about as we move forward. Again, I wanted to include a slide on MIPS and MACRA because I think it's incredibly important, and as I said, probably all of these things deserve probably an hour or more on their own, but these are value-based modifiers, and these are incentives baked into the Medicare reimbursement formula to encourage physicians to participate in alternative payment models. So this is, I think, not to be underestimated in terms of its impact. And I'm going really fast, and I apologize, but I'm trying to get through all the pieces. Next-gen ACO, we're going to hear lots more about this, so I don't want to go into much detail from Vermont. But again, it was based upon the experience of the pioneer ACOs. It's moving forward. It has goals of predictable financial targets, enhanced abilities to coordinate care, and quality of care. So, and the question at the bottom is really, I think, the one that to keep in the back of your mind as we go through all of these initiatives. And I think that is consistent throughout, which is how do strong financial incentives coupled with better patient engagement and care management improve outcomes and lower costs. Again, on Medicare, just to reiterate, there was questions when they discontinued the mandatory bundle payments. Was the federal government backing off? And I think that Tom Price also, as the initial HHS director, suggested that maybe the federal government was going to back off of mandatory value-based payment. I don't think that's true. MIPS and MACRA are still in place, and I think that the leadership at the federal level will continue to drive us down a value-based payment road. Medicaid, the other big government payer, but this one is shared between the federal government and the states. It's shared in terms of its dollars. It's shared in terms of how it is administered. But states still need to go to Medicaid under the current rules and laws to ask permission, basically, to do novel payment models. So they need waivers and state plan amendments and all kinds of things. So it's a partnership. But it is a changing partnership. Seema Verna, as I said, has clearly said that they want to reduce the size and scope of federal funding for Medicare, for Medicaid, and to reduce statutory and regulatory requirements. So that enables states to have greater flexibility to implement new and novel types of value-based payment models and care delivery models. So we'll see how that goes, but that's clearly the message that's out there. One example of this is the per capita cap. This was talked about quite a lot. And I think the important part of the per capita cap, more than the mechanics, is that it changes the relationship. And some states are already here, but at the end of the day, if you're paying a per capita amount to a state for an attributed population and the state's expenses are higher, the state is responsible for the difference, which is different than today or in the past, in the past it was an entitlement program and you had your federal share and whatever it cost, and then you put in for your federal share and you got it. So it's a different set of incentives that are being imposed upon the states, and it will likely result in some different actions by the states. Providers, for the providers, the many providers in the room, there's also provider-led advocacy. There was a recent group of providers came together and wrote a letter to Seema Verna and requested this long list of things, which I won't go through. But I think as individuals on the front lines, as individuals who are impacted by MIPS and MACRA directly, it's a really important advocacy position to have physicians coming together to help guide and how the alternative payment models actually flow. All right. Still learning and possible future trends. So, taking all of that together in terms of the federal perspective, the federal characteristics of the individuals in charge, and the changes that may come from the federal government that will guide how individuals and states work, I wanted to go through, this way, sorry, that we are still learning. The initial research on pay for performance from CMS's value-based payment efforts was not particularly encouraging. There were no great improvements. But we also learned what works and what doesn't work. We learned that you have to have large enough incentives to motivate institutions to make investments. The measures are incredibly important. I don't have it on here, but attribution is incredibly important. But these are all things that we're learning and states are designing and testing. And I think we'll hear a lot more on that from Vermont in terms of how do we actually make this work. All right, so to close, trends we may see. This is my personal list. We can maybe add to it, subtract to it. Continued federal exploration of value-based payment. Don't think it's going away. I think that if nothing else, a way to make sure we have an efficient and effective system that will continue. Increased physician participation in alternative payment models, as guided, as I said, by MIPS and MACRA. I think that will only continue. It may be changed, but it will continue. Continued commercial and Medicare interest in ACOs. I don't think that's gone away either. I think there's been a great deal of investment in these care delivery models. There's a great deal of promise, and they will continue to grow and evolve. Continued interest in bundled payments. Even though they're voluntary now, there was a lot of work done to develop them, a lot of work done to implement them, a lot of work about post-acute care savings. So those two are likely to continue as we learn and we grow. I think those will continue. Growth in Medicare Advantage, that is growing. I think that will continue as we move forward. And then changes to the Medicaid federal-state partnership. As I noted before, I think that states will be increasingly looked to as the laboratories of change. They will be increasingly put at risk for costs of their attributed populations, and that will force them to make changes in how they deliver care. And then at the end of the day, they may actually have increased rigor in terms of their managed care procurements, because that's the next stream down. For states, not every state has it, but for states with Medicaid managed care, you need to have those managed care plans operating as efficiently as possible to make sure that the state is able to afford the care. Continued commercial interest, I think that will continue. That's not backing off. We see increased trends in lots of publications from lots of commercial plans about their value-based payment models. They've put a lot of money and effort behind this. The outcomes are mixed still, but moving in the right direction. Attacking the root causes, I really wanted to include this in terms of, I skipped over it a little bit, in Medicaid social determinants of health. What is the root cause, and how do you get to manage people's care outside the health delivery system to keep them healthy? But the challenge seems to be at least twofold. One is that the ROI is long. You have to figure out how to make the argument that this is a worthy investment. And also that these are multi-sector partnerships that go way outside the health delivery system. Those things are not traditionally done. So figuring out how to, we talk about braided funding and merged funding, but doing it on the ground is really incredibly difficult. So, but I think that communities and states have their accountable care communities, accountable communities for health. They're all different names for these, but I think that they will continue as kind of the next step in the evolution of health delivery. And then prescription drug spending models as one of the really high-cost items. Applying value-based payments to prescription drugs is likely to be in our future. So just to try and sum up, and this is certainly not an exhaustive list, but we need improved measure design and selection. We've all talked about too many measures and measure madness, and we've all tried to have our own set of measures. I don't know that we've found the magic set yet. Risk adjustment, really hard, especially as you move out to attributed populations that are population-based and not, say, primary care provider-based. How do you do that? Consumer-focused measures, there's so much to do on the consumer end to ensure understanding of health and how to drive their own best health care. HIT continues to evolve to serve all of the above, the measures, the cost, the value-based payments. Reduce burden on providers, if possible. aligned incentives across payers, and I think, again, that's something that we'll hear from Vermont about, but that's another incredibly important piece. Robust ROI for everything from your acute care to your primary care to your root cause analysis. And then stakeholder engagement, and that gets to bringing everybody to the table to work together, which is another incredibly challenging task. So that is my 20,000 foot review of the incredibly challenging conditions, actually, that our colleagues in Vermont are working under to do some really, really novel, unique work, which I think we all are going to be amazingly proud of and interested to hear about. So we can go into more detail on anything, but I'm going to hand it over to the Vermont crew. And do I need to do anything with these slides? Nope, I'm good. All right. Thank you. And off to Vermont.